sometimes I wake up with a sore throat, multiple times a week. And now I'm like, I have the same exact one that I've had in the past, but now it's like running through my head, like, okay, so do I need to be tested? Because part of me is just like, I can't get it.
Welcome to Healing Together. I'm Nicholas Boileau. My guest today, Dr. Lissa Chipeco, is a geriatrician practicing in Minnesota. In this episode, we discuss what COVID-19 means for life in nursing homes and how frightening this time is for residents and staff. We get into testing dilemmas for staff, fatality rates for geriatrics, and some of the ways this disease presents. We also talk about how we can best take care of our elders, both as individuals and as a society. So, without further delay, here's Lissa Chipeco. Maybe before we talk about some of the topics that I would really like to talk about specific to geriatric care, we should go right into what's going on right now. I know we spoke before this conversation about what you were doing this morning, and there's a lot to think about when it comes to geriatrics and the current pandemic.
We are indeed in the middle of a pandemic. First time really I've lived through one as a physician. So it's interesting times for all of us.
What's going on specifically in your world, given the kind of work you do with older patients and the care facilities you work in?
I round in a 82-bed nursing home, which is a combination of long-term care patients, meaning they live there, and transitional care patients who are the people who are there short-term after hospitalization. About a week and a half ago, we had 0 COVID cases, and about a week ago, we had our first, and since then, we've had 2 more, and on top of that, 2 more people under investigation, or PUIs, as we have labeled them. So although some of our response has been planned a long time ago, some of it we're having to patchwork as things evolve. For example, there are now transitional care patients who are demanding that their families be discharged ahead of what we expected or before we feel they're ready. Understandably, because now it's running through the facility and they feel that they can protect their family members by bringing them home. And so decisions have to be made about now what? What can we offer these families as far as follow-up care, testing, how to advise them on quarantine when these are the people who need help, so they can't fully quarantine. So logistics are difficult.
What about inside the facility? You said there are 82 beds, and it sounds like you've got
3 patients and 2 under testing.
Do you have ways to do contact tracing to make sure that you know where it might have spread or come from and where it's going next?
Not really. The news is very clear about we do not have enough testing. So we are only testing residents who are symptomatic, and even moving forward with the positive cases, we are only really testing even staff who are symptomatic. Currently, we are not testing all contacts. So, for example, if you were a nurse who was taking care of this patient who turned positive a few days before and around the illness, unless you were symptomatic, meaning, one of the 5 trigger symptoms that we look for, you will not be tested. And I think for some nurses, they are also wary of getting tested because once you get tested, you would have to wait out the results, and that means no work for them. And different places have different rules about whether that is paid time or not paid time. It's a little bit of a mess, to be honest.
Oh my goodness. So if I'm a nurse and I have even the mildest concern, that's gonna be a dilemma for me because I don't want to go without a paycheck for a couple of weeks while I'm waiting for a test result.
To be clear, some places do pay for that kind of time off, but I have heard, not personally in my facility, but I've heard that in some cases, especially with aides, I think it's less clear whether the aides will get paid if they don't come to work.
We're talking on the morning of Friday, April 24th, And I know there's been a shortage of tests. Do you have all the tests you need? Like if you want to test someone, can you do it?
There are very clear guidelines where I live in Minnesota where there's a group of people who can easily get tested. And those are frontliners who are the healthcare providers, residents in group settings such as long-term care facilities, prisons, etc., and then the relatives and close contacts in households of those same people. But the broader question of who we really need to test to control this epidemic, that is the one we have shortage for.
I'm wondering if you can speak to what this is like vis-a-vis the older population. How scary is this?
It is quite scary because they hear the news, they have TVs in their bedrooms, they understand that this is particularly lethal to their age group. They don't have family visiting them because we've pretty much locked down the facility to visitors. We come in and try to provide cares and we are in full garb. And so they're always wondering, why are they dressing up like that for me? And we're always trying to reassure them we're doing this for everybody. Otherwise, they'll think that we know something about them that they don't. And then also, up until probably last week, the direction that our supervisors had was to try not to come into the nursing homes because healthcare providers tend to spread these infections at a higher rate than a normal person. And so the idea was to protect them. Well, then finally, we realized all the other things that are not COVID were still happening. You know, the congestive heart failure patients were still having their issues. The diabetics were still out of control. The people who fall frequently still fall and now have hip pain. And now the nursing staff is trying to take care of all of these things without us, and they are overwhelmed. Which brings me to my next point, which is when the residents feel that the staff is stressed, they get anxious. And then also their needs are not being met as efficiently because providers are just overwhelmed. And so when we finally got in there more regularly this past week, the staff were just so happy to see us because they were just feeling neglected and really left on their own. So I think it's scary for everyone, both the residents and the staff.
What are the fatality rates in this particular population?
The mortality rate once intubated for this age group is quite high. It's anywhere from 65 to 85% is the last number I heard.
So they have every reason to be scared.
Every reason to be scared.
I would think most of them are used to the fact that they're old and frail and life only goes in one direction. So they're approaching the end of life. But I think the way you die with this illness is particularly frightening, isn't it? You end up completely alone, don't you?
Yes, it's distressing because we're minimizing contact in a time where contact and touch are so important, right? And you don't have that in that setting. I think no one is under any illusion that they will live 20 more years. They are used to the idea of dying, you are correct. But everyone hopes for a dignified death. And I don't think you get that in this illness.
Yeah, and I would think as good a death as possible. So as good a death as possible might mean being surrounded by loved ones or having someone holding your hand or at least feeling a sense of not being utterly alone with machines when you're leaving this life.
Yes, yeah, I think I would echo that. And I think if you listen to interviews with nurses in the ICU, I think that's always what they hone in on. Just the devastation of not being able to have this person who is dying be with their families. And the effect also on the providers that they are having to be that family without really knowing anything about that patient. I think it's very emotionally taxing for them as well.
To be with people who don't have their families and basically having to provide that role for someone who's dying, maybe over and over again, depending on the facility or the job, right?
Yes, that's correct. And I think that is when you listen to their stories, the ICU staff stories, inevitably they would mention that as one of the more distressing things about this whole experience.
Okay, so we're in a dark time. And from what I understand, there's information building up very fast. People are studying what's happening in real time. We've got some of the best minds in the country working on it. What are you understanding right now and learning as you've been accumulating your own data? Maybe some of it through public sources, but some of it through your practice. Maybe some of it even just by encountering patients or healthcare workers.
I think the most important thing that people have to understand about this is how many asymptomatic people are infected out there. I think we're only beginning to realize how many and how they are able to spread this disease. There is some studies, and there are numerous that might have slightly different numbers, but if you are someone with the flu, you're typically able to infect 2 other people. If you have COVID, you are typically able to infect 5 people. So the spread is quite remarkable. The symptoms don't have to be, if you do get symptoms, don't have to be spectacular. In fact, one of the more surprising things to the ER providers or urgent care providers is how well someone looks compared to what they see on the x-ray. They are talking normally, they're laughing with their family over the phone, waiting for their results, and they're looking at the x-rays and they're just not consistent, and they can really go south and get worse within a matter of hours. So that's been challenging, trying to decide who gets admitted or who gets sent back home.
What does the x-ray show?
The typical COVID x-ray pattern is what we call bilateral interstitial infiltrates. So if you look at an x-ray of the chest, there's normally black air on both lungs, while the bottoms of those lungs are now whitish gray. And that is where the disease starts. It does something to the furthest parts of your lungs that make it fill with fluid. And although the actual lung itself is not stiff, so it doesn't feel hard to breathe, there's already something going on with the exchange of your blood and gases that is not normal. And so you can have someone who looks normal, but when you check their oxygen level with an oximeter, which we put on your finger, it will be already abnormal in a normal looking patient. With the x-ray findings being typical of COVID, then you can almost assume that that person has COVID even without the positive test.
And what's a normal pulse oximeter reading?
Typically, you shouldn't be below 92 for an older person. For a younger person, anywhere from 95 to 100% would be typical.
And what do you see in a COVID patient?
Usually you start seeing 85%, 83%. And in spite of that, they still look fairly normal. They might have a fever or a sore throat, but they're not gasping for breath.
Right. And without getting into too much physiology or biology, my belief from my experience and the little bit of training I've had in the past is that when you get into the 80s, that's dangerous territory, right?
Yes, it's not a good sign. Harbinger of poor ability of the lungs to put the oxygen in your blood cells. Yes.
Yeah, and then different parts of the system might shut down because they lack oxygen.
Yes.
So we talked about how frightening this is. Are seniors taking this as seriously as they should?
Strangely enough, some still don't. And I think that's rooted in their view of themselves as already being old, having lived a life, or having gone through spectacular hardships and survived. They either have an invincible sense of themselves or, quote, I've been through this, I'm done, unquote, which is dangerous because they really have to understand it's not just about them, right? It's also about the people around them and the people taking care of them.
In our life, we have a person who's very advanced in age and who doesn't seem very concerned about getting the disease. She's lived her life and she's comfortable moving on. But I think what's surprising me is that it doesn't seem to matter to her as much as I would think so, that if she does contract the disease, she will then expose the rest of us to it because we'll want to take care of her, or she'll be alone. And even if she's alone in a hospital, then she'll be exposing health workers. She'll be one more case that they have to deal with, one more likelihood that they will spread it to themselves and their families.
We do have people who think that way, and I get it. I understand the idea of having lived their lives and being ready to move on. I think there is some magical thinking going on in those peoples. They somehow feel like they will get this illness and they'll be at home comfortable until they die. That's not necessarily the course, and we can go through some of the stories I've heard if you want to, but it's not necessarily a comfortable death. If you do contract the illness severe enough, I think most people will end up wanting to go to the hospital just for comfort measures, even if they don't want to be ventilated. But then that's when you find one more person overwhelming the system, right? And I don't know that the older people who are feeling this way, they are not thinking that far ahead. They are just thinking about the disease as a philosophical hypothetical, that they are ready to go. And if this is the way they go, then it's fine with them.
Yeah, well, maybe this is a good time to talk about what actually happens when you contract the disease, because you've seen people with the sickness. I think you told me, we spoke a little while ago, and I think you told me you had had your first video visit with a patient who had COVID. Now I imagine you've seen more. Can you talk a little bit about the progression, what happens? And after that, I'm going to ask you, what are the best things we can do if we have seniors in our life or people who are frail and potentially at high risk of dying? What are some of the things we can do? But let's first talk about what it looks like.
Okay, first of all, I'd like to make it clear that I am not an intensivist, so I might not be the best person to really get into the nitty-gritty of how this illness looks like in the final stages. But I do have cases in the facility I go to, and we do have case presentations that we follow. And the way I understand it and the way I'm seeing it clinically to some degree is that people start with a mild enough symptom, typically a low-grade fever or a cough. The fever and the cough will quickly escalate over 2-3 days or so. By the time they have some shortness of breath, the progression from mild shortness of breath to severe shortness of breath would be just hours, really. And patients have described it as a feeling of drowning, which makes sense because the lungs are filling up with fluid. And so it happens very quickly. The decision to intubate someone happens very quickly, and that's why you have stories of people being in the ER sitting, and then suddenly the team has to code on them because they just crump, is the medical slang for someone suddenly deteriorating quite quickly.
Can you say that word again? So they're sitting in the ER, and I think when you say the team has to code, it means they're at high risk of dying?
Yes, so they suddenly slump over with abnormal breathing patterns, and then they are what we refer to as crumping, CRUMPING, which is suddenly deteriorating. This is someone who is either going through cardiac arrest or respiratory arrest, and that's where the code happens, which is chest compressions, defibrillator if you need it, intubation to help the airways. These are happening in different ERs because of how fast the worsening happens.
Have you seen any patients recover?
Yes, we do have some good news. We had a 102-year-old patient, female patient, not in my facility, but in a colleague's facility in our metro area, who was quite sick with COVID about 2.5 weeks ago now. I heard that she was recovering and, in fact, thriving and smiling last week.
Did she have a severe case when she had it?
She had a severe enough case that she was comfort care in the hospital. There was a decision prior not to intubate her per her request and her family's request. So for all intents and purposes, they expected her to pass away. But by some miracle, she is still with us today.
And do you think that's because she's a Minnesotan?
Who knows? That's what they say. We're pretty hardy. There's also some discussion about whether or not we're doing patients a disservice by intubating them. I think that question is out there. We don't really know the answer. We know that once someone is intubated, they do poorly. Is that because they were so bad to begin with, they needed intubation, or something about the intubation themselves that make them do worse? We're not sure.
Intubation is very uncomfortable, right? It's basically putting a tube into your lungs to pump oxygen into you.
Yes, so you would have to be put in a medical coma for this to happen, because most people in that stage of illness are also delirious and confused. So you don't want them pulling out their tubes or IV lines.
Okay, well, this has been thoroughly depressing,
Glad to help.
but I think maybe we can move on now to talk about geriatric care in general and health and wellness in old age. Aside from this COVID-19 pandemic, presumably some of us will survive to exist on the other side, and we have a population pyramid that's changing dramatically. We're getting older as a population, and the oldest among us are increasing in number. Out of interest, what types of environments, based on your training and what you've seen, are the ones where older people tend to thrive more?
Older adults thrive more in a setting where they can live in a multi-generational household. That's a little bit rare in the US, but when you do have seniors who live in that setting, they tend to do better. I think just being able to exist in a household where there are multiple activities going on, both at their level and at their grandchildren's level, that helps them, quote, stay young, unquote. I think also if they can stay independent in their own place, like an apartment or a condo, or even a low maintenance home, I think that is when people tend to thrive more because they're in charge of their own decision making.
What do you think it is about living in a household? Are there specific things that happen there that make life so much different than if you were in a long-term care facility or isolated in your home, with your kids spread around, your kids and grandchildren spread around the country?
I think it has something to do with having a choice. I think when older people can choose simple things, even like what time to wake up, what to put on to wear, what time to have breakfast, what to do with the rest of their day, drive or not drive to the pharmacy. I think when those choices are available to them, they feel like they have a life, which they do. When they are in an institutionalized setting, those choices are taken away from them. And although they are technically safe in a long-term care facility or an assisted living facility, that comes at the price of not having your own choices and quality of life.
Right. It's almost like you've become a plant and you're well taken care of and fed and watered at the specific amounts. I mean, they're very precise, right, about caloric intake and nutritional intake, but somehow something is missing that's fundamental to being a human being.
Yes, that's true. And I think part of that is because as a society, we have put safety as a priority. When you talk to children of parents when making decisions on how to proceed with deciding on a living setting, you inevitably hear something like, I just want him or her to be safe. I want dad to be safe. I want to be able to live my life and not worry that he passed out or fell or burned, the apartment down because he still cooks. So I think as a society, we've placed a lot of value on safety without really thinking through the repercussions.
So I think independence, but in my mind also engagement, and this is completely anecdotal, so tell me if I'm barking up the wrong tree. When my mother died, she was incredibly healthy. She had the previous year hiked a 14-mile trail through difficult woods. She traveled. And what I didn't know is that she had lost some sense of usefulness or purpose. She got diagnosed with a glioblastoma multiforme, which is a brain tumor, or she actually had several. And we had a very, very short time in which we needed to discuss how aggressive we were going to be in treatment and how much she was going to fight this versus trying to keep her comfortable and letting her go. And she chose very quickly to go. She was only 70 years old. And again, she was physically very healthy. And at one point, we had this incredible conversation where I was evidently disappointed and trying not to show it too much, but I was frustrated. And she said, I'm all alone. Sorry. She said, I'm all alone. I have a grandchild on the way. But how often am I realistically going to see that child? And what is my role with any of you? She was talking about her children. And I've never forgotten that because it seemed like it was such an essential part of life, was not being taken care of, but being a caregiver, being useful to other people. And she had lost that sense that she was important in other people's lives. Can you speak to that at all?
I think intuitively we know that people need to have something to get up out of bed in the morning. A sense of purpose, sense of being useful. And that doesn't become less true just because we're retired or are more frail. All those things that motivate a normal, young, healthy person still is true for an older person. So when someone has defined himself or herself a certain way, whether it's the CEO of a company or the matriarch of a family, once frailty gets in the way and he or she is not able to provide that, of course, there is a diminishing of the will to live. I think I mentioned to you the book Being Mortal by Atul Gawande in one of our conversations.
Yes.
A small part of that book talks about a physician in a nursing home who had revolutionary thinking on how the nursing home should be organized. They have multiple dementia patients, frail patients, who were really not participating in much of anything or minimally participating in the recreational activities. And so he had this idea of bringing in house pets that the residents will be in charge of, putting in a vegetable garden for the residents to sign up plots for, and assigning residents with taking care of 2 parakeets each if they wanted to. And there was a transformation that happened in that nursing home where the residents were actually coming out of their rooms. They're interested in what's going on with the animals. They're out in the backyard planting their vegetable or flower of choice. And the staff actually eventually realized it was so much easier to take care of them because they were engaged and moving around. And I think this is an example of just the simple things that make life worth living. If the residents felt like they were responsible for feeding that parakeet or walking that dog or brushing that cat that they had, even those small things are enough. Being able to provide care to another living thing might be enough. So in your mother's case, I think her feelings of being useless, I get that. I think that's a valid emotion to have at that stage in her life. And I'm glad she opened up to you. I think that's important. I don't think most people would be as candid. And I hope you and your mother found some resolution.
Oh, that's nice of you to say. Yes, we did. And she had really a beautiful passing, if you could call it that. And I'm surprised at how something that's almost 21 years ago can still affect me. These are really important relationships. And I think, as in any important relationship, it's often difficult to dig into the most important topics with the people you're most intimate with. And especially important or especially difficult for a child with a parent, because it's kind of a role reversal. You know, the discovery of what the needs are and the wants, and actually trying to get to the real need, is probably a conversation that most parents and children aren't used to having in that direction, right? The child having to find that out from the parent versus the parent taking care of the child.
Yes, and so much of this depends on the inherent family dynamics already in place, right? Some find the transition between being the child to becoming the caregiver or the so-called authority figure easier than others, and some find it very difficult.
Yeah.
These are very common scenarios, and I see it play out in clinic setting and the nursing home setting. The discussions about decision making when the wishes diverge can be quite spirited and interesting.
And does that happen often, the wishes diverge?
Yes, I would say about 50% of the time you would have some sort of struggle or battle of wills. The most common scenario is when it gets to the point that the ability of the older adult to live independently is becoming questionable, and decisions have to be made if they need to move to a different, more supervised setting. That would be probably the most common contentious discussion that happens in my practice.
And here you are as a doctor trying to advise about medical care, but I imagine you also have to do some family therapy.
Yes, I'm not a therapist, but yes, sometimes that role is forced upon us. These are difficult decisions and discussions that are not going to be solved in one clinic visit. And most of the time, it ends up being multiple conversations, either with the family or just alone with the patient. And this is again where the struggle is when society puts a premium on safety versus what the patient or the older person really needs to have a meaningful life. They're always thinking about that scenario of the fall when nobody is around, resulting in a hip fracture. And of course, you should worry about those things. But I wish there was a better medium of recognizing that risk and mitigating for it, or having a plan in place that says if this happens, this is what we want to happen next. Unfortunately, those kinds of discussions don't happen in a regular basis, and so decisions are being made in crisis mode. And that's when things get a little bit tricky.
I think most of us would choose, if we get to an advanced age and we're lucky enough to live that long, we would choose fewer years with greater living than more years with greater safety.
Yes. And, if I could show you a visual, what you would really want as a life trajectory is like years of good quality of life and a sudden decline. leading to death, right? That would be what most people would think is ideal. But that in the past few years, because of advancement in medicine, technology, and just in general, for many different reasons, longer life expectancy, that trajectory has markedly changed. It either is this slow, dwindling decline to death, or this fluctuating curve of several weeks of feeling good and several weeks of being ill and hospitalized, a few weeks of improving, and then back to the same fluctuating course. And it is maddening because if you would ask people, most people would not want that trajectory, and yet that is what happens now.
I don't know that many people who are living every day in their work life with and around people who are approaching death. How does that change you as a person?
I think it helps me stay in the present. It makes me realize all these people I see have led full lives, robust lives, and yet they're here in my clinic now because they need help, because they are aging and more frail. And it puts things in perspective to me. I could have this life that is full of fun and ambition and intellectual stimulation. I could have all that presently, but that's not going to last. And how do I enjoy every minute of it? I think immersing myself in that world of seniors who have gone through that, I think helps me realize what I have and enjoy it more and value it more. The other important thing that it helps me with is it eases my fear of dying instead of accentuating it. I think the fact that I see dying and death over and over again somehow makes it less scary to me. I used to have a mentor who used to say half jokingly, well, no one's getting out of here alive. And I just find that so true and funny in a morbid sort of way. Like everyone will leave this world. And if you know that, if you really knew that, I know everyone knows that they're going to die, but if you really knew that you had a finite amount of time in this world, I would hope that that will help you really appreciate everything it has to offer and experience everything within your reach while you are healthy and able to.
That's beautiful. I had a diametrically opposed experience when I volunteered in a long-term care facility in hospice, where it wasn't a very high-end one, and I found it so utterly depressing. I remember this one time I was asked to help make cookies with the residents, and I had a woman showing me how to do it. She brought me to a room where all the residents who wanted to participate in this, and I say participate it's a very liberal way of saying it, were assembled in a semicircle. Some of them were staring at the ground, some of them were staring at the sky, some of them were just staring vacantly and drooling. And I had thought we were going to make cookies together, which sounded kind of fun. But she just said, hey, everybody, watch as Nicholas mixes the ingredients. This is how she spoke. And show them the ingredients, Nicholas, show them. So she had me go around and show these people the bowl and the fact that I was mixing ingredients in a bowl. They had absolutely no participation in this process whatsoever. And I remember leaving that day and thinking, my days here are numbered. I had been volunteering for a few months, but I had found the experience so deeply depressing, and all it did was fill me with terror that I should end up in a facility like this one.
So I think if you are able to, what am I saying? Hold on.
Well, and I may not include that depressing story about.
I think you should. I think it helps people Because, people will listen to me and say, wow, she's a fruitcake. And I'm okay with that. They have to feel normal. It's good to have people who have similar feelings and you not feel guilty about that. Not everyone would have the same experience as I have working with older people. I can see why it would be depressing, and that's okay. They don't have to feel warm and fuzzy being with older people all the time. That's not necessarily a, right or wrong reaction to it. So I think you should. I think that actually your reaction is probably more kind of common. And I think also you had the disadvantage of really being in maybe a more memory care specific wing of the nursing home where they are unable to cognitively do anything or participate. So I can see why that would be very much a downer.
So, can you talk about what you feel from your perspective as a geriatrician? What might need to change in the way we view the elderly in our society or our culture?
I think the most important thing is not to think you know them just by looking at them as they are now. You're looking at the impaired gait, the hearing decline, the cognitive difficulties, the stubbornness, etc. Let's not reduce them to their least functioning parts. I mean, these are people who have led complicated lives, lived through events that changed them for better or worse. They evolved as necessary and they survived. They have stories, which, guess what, are interesting if you took the time to listen. They have opinions and you might not always agree with them, but they're always born out of historical events in their lives. And, we all just might learn a thing or two.
That sounds really respectful. How do you handle it when those opinions get really, really strong, when they stop censoring themselves, more easily saying hurtful things? It seems like there's a defiltering that happens sometimes.
Yeah, so we call that the disinhibition. It depends, I guess. If the disinhibition is happening because of a medical illness, like it's quite common in Alzheimer's dementia or frontotemporal dementia, then we would all have to try to think of it as the illness talking, so to speak, and redirect as we can. Now, if they are just naturally like that anyway, they have a baseline challenging personality, which is just accentuated either by aging or by declining mood, my advice is to have a conversation with that person and say something in the lines of, I really want to spend time with you. I think our time together is limited. And it's hard when you say hurtful things like that. Can we find a way to spend time together and avoid those painful comments? So, that's all you can do, right? You have to make a decision whether or not you'll engage in a negative way or try to make your last few interactions with your loved one positive and pleasant and loving.
It's so interesting because similar to a parent-child relationship or a spousal relationship, sometimes you can hear something from someone who has clearly lost their full faculties. They may be there 90 or 80%, but they've lost the full range of emotional control or, cognitive ability. And it can still deeply affect you because of the intimate relationship you've had before. Whereas, like, if I go hear your parent say something hurtful to you, or even to me, it's going to roll off my back because I don't know this person that well, and I'm just going to think, oh, she's having a bad day. But if it were my parent, it would be a very different thing. And even though I can have the same knowledge about the person's condition, I have a very different emotional reaction to the things they might tell me.
Exactly. I think if you have a history with a person, everything is in context to that history. So this is where the challenging conversations are had about decisions that are made around the person's healthcare. This is where it appears, right? Because, for example, when the family is trying to come together to make a decision about the older adult in their family, usually the parent, right? All those past hurts and feeling of neglect or resentment, they eventually come to the fore because everything becomes
brittle.
Yeah, every opinion is being perceived as a retaliation or um, or a comeuppance in a way.
Yeah, and it's also a very tense time. I've been talking to people in this time with the coronavirus, and we've been noticing how the tension and the fear and the being home altogether is exposing whatever cracks may have been under the surface in a lot of family dynamics. And I think the time of a parent or grandparent dying has the same effect because, that's where everything comes to the surface and bubbles up, and there are big emotions happening.
So I think this is also why these decisions shouldn't be made in crisis mode. So I'm going to put a plug in for all seniors and caregivers to really think about getting an advanced care directive in place. Not so much that the idea of wanting or not wanting resuscitation is the most important thing. I think just having families sit down and talk about these things also is an opening to a conversation about what that older person really wants. What is their definition of quality of life? What is important to them if time is short? And I think if those conversations were happening, then it's easier to make decisions moving forward and also to plan for those decisions.
That makes a whole lot of sense. I know we're running out of time, and I'm wondering if we can just very quickly do a few rapid fire questions. But before that, I just wanted to ask this question that, needles me. I think a lot of older people continually hear advice about what they should do, and there's a lot of alternative modalities that are now within our popular culture. You should meditate, you should do yoga, you should do a walk every day. That'll make you feel better. Are there any specific things that fall under that nomenclature alternative modality that you've discovered your patients have explored successfully and really make a difference? Like, is there a top thing or two things that they do that often gives them more vitality or comfort or better feeling about their life?
I would say meditation is up there. I think it has value as far as anxiety, and you would know this much better than I do too. It has effects on anxiety relief and also blood pressure control. So that's one. I actually encourage them to do Tai Chi, which I don't know if it necessarily falls into alternative modalities per se, but that whole balance training is really helpful. And there are studies to back that up. Acupuncture is another one because, as you know, older patients and the frail ones do inevitably have a lot of pain complaints, and medications are, trickier to use in that population. So I've referred a lot of people for acupuncture, and I would say a fair amount of them, especially for musculoskeletal issues, they do get substantial relief.
Thank you. Do you have time for a few rapid fire questions?
Sure, go ahead.
If you could think of 3 or 4 things from your experience that healthier geriatrics have in common, what would those be?
I would say financial stability. Unfortunately, you need that. Community engagement and regular family interactions.
Knowing what you know about aging, what are your own top self-care habits?
I exercise a lot more now as a practitioner versus when I was younger because I see how helpful it is. I try to eat a vegetarian diet. I'm not super strict about it, but mostly on weekdays, I try to keep my diet vegetarian. I leave work at work and try not to do leftover work at home. And I don't know that this is specific to me being a geriatrician, but I try not to immerse myself too much in the news nowadays. Helps me keep my sanity.
What are your biggest concerns for your own life as you get older?
I think who would help take care of me? I have 2 sons. Research would tell you that having a daughter is better for aging seniors. I think there's actually a small study that the conclusion is that. And also, this is not my country of origin. And so if statistics are correct, i.e., I would outlive my husband and my two sons will have lives of their own, and me not having a daughter, that's a big thing on my mind. I also fear being cognitively impaired and yet physically healthy, or vice versa, physically impaired and yet cognitively healthy. That disconnect I am afraid of, because I think it puts people in a very hard situation.
Yeah, of course. If I had an elder in my life who is still living at home or in his or her home, and I could start a single regularly scheduled activity or make one change in our life or do one thing that you see missing from the elders and families you've known, what would you recommend?
Oh, there's so many. I would say dedicated time once or twice a week of doing something they specifically want to do. Not something you necessarily thought of for them or something you heard about that so-and-so did, but having them choose what they want to do in the time that you have together. Of course, some people will need cues, right? Like I said, their world has become smaller, and so maybe they don't know what's out there. But I think you can start a conversation and leading them to certain options. But the important thing is that they choose, that they're the ones who chose the activity.
So I might think that my old dad should go for a walk, and I might take him for a walk, but he would probably rather play a game of cards with me. You would say, play the game of cards.
Play the game of cards once a week, or just say, hey, it's our date night. What do you want to do today or tonight or whatever it is? It's date morning. What do you want to do? Yes, I would value what their choice is over the so-called healthy option.
If you had to recommend a single book that could help families wrestling with end-of-life issues, what would that be?
By far, I would encourage everyone to read Being Mortal by Atul Gawande. It is such a remarkable book. So much information written in a very accessible way.
We'll add that to the podcast notes. And last question, and you've partially answered it, maybe the top practical books or websites you would recommend to people caring for an elderly person.
There is a book out there by Virginia Morris, How to Care for Aging Parents. It's a very dry title, but it has a lot of practical and I would say senior-centric information. Because there's a lot of seniors out there with some cognitive decline or dementia, there's also the 36-hour day, which is dementia-specific, but also is very helpful as far as the challenges surrounding that illness. So as far as websites, each specific state usually has senior services department. Ours in Minnesota is Minnesota Senior Linkage Line, so there should be a version in most states, if not all states. There's also Elder Care Locator, which is run by the U.S. Administration on Aging, and it gives you some links and information on benefits, care options. It links you to care providers. So it has a lot of useful information there. And then there's also Caring Connections, and that one is run by the National Hospice and Palliative Care Organization, and that is useful for finding out about how to talk about and fill out an advanced care directive, planning ahead for the choices that you made, how to go about medical decision making. Really good stuff.
Well, this has been a great conversation. I know you spent more time with me than we originally planned, and I really appreciate it.
I'm happy to talk with you. This is really also very helpful to me. Reminds me of why I do this job.
Well, let's plan on doing it again at some point in the future.
Yes, that would be nice. That would be really good.
Thank you so much.
Thank you.
Healing Together is produced by Healthenly. Our theme song, Ramble, is composed and performed by Ed Morneau.